Assalamu alaikum everyone. My name is Sadaf Ehsan and I'm one of the doctors who've been working in UK for a few years now. I hope everyone can hear me.
Ji Dr. Sadaf, Dr. Khalid Google from King Edward Medical University, Vice Chancellor, King Edward Medical University.
Good morning, Dr. Khalid. Um, I would really like to thank Impact today, who's given us a chance um, and a platform to actually discuss on this important subject. Before we go any further, I would like to introduce Impact to you guys who are new to us today. Um, Impact is actually a voluntary and non-profit organization, which was initially based in UK, but now has extended its arms across the world. The idea is basically to provide a platform where intellectuals and academics from our motherland, Pakistan, can actually gather together and, on the basis of their prior experience and expertise, train, or shall I say, equip ourselves, our colleagues back home with this current and global pandemic called COVID-19 and against the virus. Before I go any further, I would just give you a brief introduction for today's session. As I have said before, COVID or no COVID, this is one topic which is absolutely essential for us to discuss because it not only affects half the population of the world, but actually affects the norms of our life. COVID-19 has managed to challenge us in many ways, whether it's physical, emotional, or social. And every journal, newspaper, TV channel you open, there is always something new and interesting about COVID, and people are eager to tell you something new, which may or might not be true. Hence, on this platform, we always call the speakers who have the knowledge and up-to-date acumen, which they can provide us with, and we can take it from them and go further. Before we move on any further, I would like to thank the Government of Sindh and Vice Chancellors of so many universities who have joined us today. Yarane Watan from Government of Pakistan, and all the participants who are joining us. Thanks once again for joining us for this important session. We've got two important people that we thought we will who would like to speak a couple of minutes and enlighten us with their presence. I would like to invite Dr. Khalid Masood Gondal. He's the Vice Chancellor of King Edward University, to please say a few words for us.
Dr. Sadaf, thank you very much for inviting me. I have been regularly attending your sessions of Impact, and I think you are contributing a lot in academics and research during this COVID pandemic. And today's your topic is related to one of most important specialty, that is the gynae. It's something about the infertility and role of the IT information technology. I could see the names of very senior Professor Azizen, Nissa, Muzaffar, and yourself. I just wanted to share one thing, that College of Physicians in Pakistan and King Edward Medical University is also expanding this specialty. And recently I have approved 4 new departments, subspecialty at King Edward Medical University. These are specialty related to the infertility, urogyne, gynecological oncology, and fetal medicine. Thank you very much. I think you are doing a wonderful activity. Keep it up. My salam to you, Dr. Said, and everybody listening to me. Thank you.
Thank you so much, Mr. Gondal. We really appreciate your comments. And congratulations to you too for doing such good work in King Edward. I think this would be the 5th department in the last few weeks that we've been hearing that you're extending. I hope you keep up the good work, and best of luck for your future endeavors. I would also like to invite Mr. Talib Lashari, who is advisor to the Minister of Health Sindh, to say hello to our team here. Thank you so much, Dr. Lashari. If you can please join us.
Thank you, Dr. Sadaf Hassan. Thank you, Dr. Ghaffar Ansari and the Impact UK for inviting me to this very August gathering. Um, I'm representing the Population Welfare Department, Government of Sindh, as well as family planning work, which we are doing in the province on behalf of the government. For the sake of some of the August this gathering, as well as some of the very distinguished specialists from UK, as yourself and other, I would say a few words about what we are doing, and then would add few things about what we have been doing during the COVID on family planning and reproductive health, and would conclude by saying what is required in near future and beyond. We are working on family planning and reproductive health, uh, especially under the international commitments made at London Summit in 2012, when the world concluded that the uh, the objectives under Millennium Development Goals uh, were not being achieved by 69 countries of the world, I mean the developing countries. So for those 69 countries, a world summit was held in 2012 at London, whereby DFID, UNFPA, Bill Melinda Gates Foundation, and the governments represented by their prime ministers and advisors, they gathered, and Pakistan was amongst that gathering, and Pakistan committed to increase its family planning indicators by the year 2020. That's why it's called FP 2020. So Pakistan committed to increase its contraceptive prevalence rates from 35 in 2012-13 to 50 percent by 2020. Uh, and one requirement was to develop a roadmap called Costed Implementation Plan, CIP. In Pakistan, since 18th Amendment was introduced in 2010, so it was required for each province to develop their own costed implementation plan in Pakistan. And Sindh was the first province, and perhaps the only province, that has developed costed implementation plan in 2015, which was approved in December 2015, and later on was funded by the government of Sindh. And we have been implementing this. And our goal was to achieve 45% of the CPR by 2020. We had calculated unmet need, that is, as per data of PDHS and MIX, 1.8 million women of reproductive age, or married women of reproductive age, to be reached. And for 45%, we required less than 1 million additional users of family planning to reach to this goal. Unfortunately, there are lots of issues, problems in the systems, and then so many external factors like education, girls' education, adolescent awareness, and acceptability, and the availability of the services. So we have been able to, as per our CIP database, we have been able to reach to 34% of the CPR as of now. And but as per Track 20, Washington DC, that is measuring the progress of 69 countries of the world, they have calculated the SIN CPR at 33%, around about 33%. But PDHS 2017-18 has put it at 31%. So although we are within the confidence interval, but definitely we need extra efforts. In the meantime, COVID struck. I mean, COVID is a pandemic, global pandemic. So it has definitely affected the services. And during those past 6 months, family planning services have suffered a lot because fear of the providers के PPEs नहीं हैं तो कैसे अपनी सेफ्टी को हम करें लिहाजा we decided to continue the services at the hospital-based reproductive health services centers of the Population Welfare Department, Department of Health and PPHI. And also the partners are with us, all the NGOs supported by DFID UK, supported by USAID, supported by Bill and Melinda Gates Foundation and UNFPA. They are supporting the Sindh initiative, which is led by Dr. Azra Fazil Pejuhu, Minister for Health and Population. And she is the soul behind this whole movement in Sindh for the past 5 years or so, even beyond, before that. So during the COVID, we, with our partners, diverted the resources towards COVID-related trainings and COVID and family planning and reproductive health related needs. More than 600 providers have been trained by different partners, UNFPA, JSI, and Pathfinder, and so many other. But I would appreciate the role of the Impact UK in this regard, that they have also been very active. And I applaud your support because you are doing this on voluntary basis. And you have been able to train, hundreds of doctors online, because this is the new normal that we are moving from face-to-face physical presence training towards online trainings, which is very, very useful.
Thank you, Dr. Talib. That's really, really helpful what you've just said and given us a brief insight into what's actually happening in Pakistan. I'm sure lots of us here today will really appreciate your input in this. Before we move forward, I'll just mention the topic once again. I'm presuming I've actually not said that yet. Today, we are going to discuss the up-to-date knowledge and evidence that's available regarding female sexual and reproductive health. And I've got two very, very interesting speakers. I hope I could do justice to their portfolios actually. The first one is Dr. Azizen Nissa Sheikh. She is a former Liaquat National graduate who started her initial training in Pakistan. Then she's moved from there to UK, having worked in various cities of London, so various cities of England. She finished her CCST in 2006, and from there on she moved to Dubai. She has worked in various different private settings in Dubai as well, and currently and after having the experience of working in 3 different countries, she decided to finally bring her work together. And currently, she started her private clinic back in 2016 called Nissa Well Women Clinic. The ideology behind which is basically a holistic approach towards women's health, which includes physical, emotional, and social well-being of the woman. And for today's discussion, who better than her could probably give us a few thoughts regarding what has changed during Corona times. Over to you, Dr. Azizen Nissa Sheikh, please.
Hello.
Assalamu alaikum.
Alaikum salam. So thank you for your introduction. The first thing I want to clear, I'm not a professor, I'm only a doctor. And all my life, I have not gone after the title. So my main aim is to deliver the service. And second thing is that, yeah, I'm in Dubai, but I've experienced, I know my heart is always in Pakistan, so I can visualize what's happening. And I have worked in Hyderabad Civil Hospital. I have worked in Karachi Medical Hospital. I know what is the situation there and in what situation people are working there. So my hat's off to the people who are facing the pandemic in a very dignified way, and is much, much better than USA, America, and England. So I'm very proud of that. I'm very proud of Dr. Talib because He told us the insight of the family planning and reproductive medicine in Pakistan, which is very advanced, because the places I have worked in England, in Dubai, in UAE, family planning and reproductive medicine is not an issue because it's a part of the medical services. And we amalgate the sexual health in the gynae services. But I know it's a big challenge for Pakistan. And I wish that their FP 2020 go ahead. I'm proud that they have achieved 34% of their target. And it's not really the targets reaching. I know Bill Gates and all presidents will set the targets because they fund it, but the main aim is the women health in all. And family planning is by choice. It should not be forced. So the main thing is that if woman is healthy, the family is healthy, and a good structure of a family, and children are looked after, that's the aim. I remember I saw an Urdu movie where there's a character and the father was angry with the girl, and girl said, "Agar paal nahi sakte ho, to paida kyun karte ho?" So I think, so if a person is very rich and he can afford 10 children, no problem. Problem with the poor people when they have 12 children and they can't. Okay, so my presentation is, and I want to also change the word training. It's not training, it's sharing the knowledge and sharing the experience, so we all can get benefit of it. I don't want to train people who are already self-trained and they have learned from their experiences. In the end, we learn from the experiences. Their guidelines, their policies, we can follow them. So should we start our presentation?
Thank you. Thank you so much, Dr. Azizen Nissa, for the few corrections you've made. You say you're not a professor, but your portfolio and you sound like a professor, I must say. If you can please share your presentation so that everyone can see your presentation, that will be very helpful. And I think we should make a start now. Thank you so much. Over to you.
Thank you. Okay, so basically, corona disease is there, virus there, and we are going to talk about, we'll have a general view, what is the impact of COVID-19 on sexual health and reproductive health. So the main person who's guiding us all through this pandemic is WHO. So WHO is our godfather, and they have recognized that sexual health and reproductive health is one of the human rights. So it's now classified as essential health service. So like many health services, but it has become a challenge because every health service and every specialty has become challenging. This is also challenging. But we should, the choice of the woman and the right of the woman to have the sexual and reproductive health should be respected regardless of COVID-19 status. Sorry. So as contraception is the part of the sexual health, so effective contraception is must, and it has effect on mental and the physical well-being of the woman. Unwanted pregnancies obviously will increase the maternal morbidity and mortality, because if the pregnancy is unwanted, women will go for a legal method of termination of the pregnancy, and it's going to kill them. Good family planning also reduces the unwanted pressure on the health services, which are under tremendous pressure already. If there are more pregnant women than expected, than norm, obviously the health service is overburdened by the COVID patients. So family planning will help in this case. And from my point of view, all family planning methods are safe, but it all depends on the suitability of the, what the country thinks is suitable. So every country has different ways to deal with the contraception. For example, in UK, most of the women are having implants. Here in Dubai, we are putting more IUCDs because we have safe environment, we have sterile settings, and we have a lot of private medical care, so it's feasible. But the countries of third world, sorry, I should not say third, the developing country, they need more non-invasive methods. Okay, so what is the myth about COVID-19 in pregnancy? The incidence is same in women as other population who are in reproductive age. And the good news is that morbidity and mortality is reduced as compared to other population. I remember when SARS came, SARS was the killer of pregnant women, and I myself delivered women who were ventilated, and 80% of women died. And if pregnant women got SARS, it was notion that she's going to die. So WHO has released clinical guidelines on the caring of the pregnant woman during pregnancy, interpartum care, breastfeeding. And this all comes under the document of maintaining of the essential services, operational guidelines of COVID-19 context. And it's so in so much detail, it's so much changing. So I usually, or we all, and all the countries I know, they're keeping an eye on that. And then with the help of the clinical judgment and the help of the experts and the specialists in that country, all these guidelines are made and they're released. So as I told you, that pregnant women are not at higher risk of severe disease other population. So the pregnant woman should take the same precaution as other general population, means isolation or social isolation, and good hygiene and wearing the mask. I think there are very three simple things which everybody can get used to it and should obey it. So, but the pregnant woman with COVID symptoms, any woman who has flu-like symptoms should be tested because she's carrying another life in her body. So anything can happen to her. So her status should be known. And once we know the status, it's not necessary she goes to the hospital to be admitted. At least she can be properly looked after in a room where she can be isolated and she can be looked after. Now, it's very unclear that pregnant women can pass the virus to the unborn child because the virus has been not found in amniotic fluid and breast milk. And even the newborn who are born, although they have immunoglobulin M, which cannot pass from the mother to the baby in utero, but that could be the neonatal contact with the mother. Now, all the women, pregnant women, have a right for high quality of care before, during, or after childbirth. And all the women should be treated with respect and dignity. We saw so many video clips where women are delivering in rickshaw, delivering in the car, delivering on the road, because the hospital didn't know the COVID status of the patient. And this is not good. This is, any woman who is in labor or who's not well should be immediately taken to the hospital, and the staff has to just wear the PPE. But she should not deliver outside on the road because they don't know her COVID status. So dignity is very important. She should have companion of choice during childbirth. So in my part of the world and in UK, usually husband is the companion. And initially in UAE also, they inhibited the husband to be with the lady at the time of birth or cesarean section, but it had a huge impact on the mental status of the woman, because after the delivery, the woman had nightmares and we had to refer them to a psychologist. So it's very important that there should be a companion with the woman at the time of birth. Clear communication with maternity staff is very important. What I really found in Pakistan was the pure communication. I know doctors are very busy. I know health care system is overburdened, but simple thing कि भी मेरे पास कोई जवाब नहीं है, मैं बहुत busy हूँ, इधर चली जाओ, उधर चली जाओ. I think we should take the responsibility and we should have good communication. We know you all are very busy, but good communication is very important. And appropriate pain relief is again one of the human rights. We should not let suffer any woman during childbirth with pain, because painless delivery is her right. Not every woman should go through the pain when they give the birth of baby. And if COVID-19 is suspected or confirmed, it is very easy for the healthcare providers that we just wear our PPEs. We have just a shield on our face, we have gloves, we have a gown and a mask. That's all we needed. And now it's available to everybody. Even sweepers are wearing PPEs, and the waiters are wearing PPEs. So this should not be a problem. Now, let's talk about the antenatal care. I'm just giving one slide for the antenatal care. I don't want to give it details. I know we have very, experts in Pakistan. They know more than us. So routine antenatal care should be followed. And these are the RCOG guidelines. This is ACOG guideline. This is the guidelines of the perinatal society. So it's nothing different. But I think WHO has said minimum a woman should have 8 contacts with the healthcare provider. So COVID-19 is not the excuse that women should be denied of the antenatal care. So obviously the first visit at 12 weeks, we need one visit at first trimester, we need one visit at 20 weeks to check the baby to see any anomalies are there. And we can plan the pregnancy depending on the 20-week scan. And then if possible, 26, 30, 34 week visits with the ultrasound to see the growth of the baby. 36 is again very important. She is in the 9th month, which is very important for the woman. And again, we need to know everything about the woman. And then 38 and 40 weeks are near the birth. So WHO says 8 contacts. In Pakistan, maybe they can change it to 6, whatever is easy for the woman, because they have to travel from far distance. So as I told you, early pregnancy ultrasound, 20-week anomaly scans are essential. The woman should be counseled properly in this COVID era about the healthy eating, keeping physically active, prevention of excessive weight gain, use of folic acid and iron supplement, because even in UK, we saw the women who were a little bit obese and not looking after themselves, or who have polycystic ovaries, who have insulin resistance syndrome, which happens in more Asian population. They become high risk for the COVID. Vitamin D3 has a very, very important role during pregnancy. I put every woman on vitamin during the pregnancy, because vitamin D is the only vitamin, if we take in this COVID period, it reduces your risk of getting the virus and making it more serious disease. So the optimum level of vitamin D3 are very important. And obviously we should not miss the gestational diabetes, because in Pakistan, as we have metabolic syndrome, very common in men and women. So in women during pregnancy, gestational diabetes should be screened. If woman is not diabetic, then we are saving her from so many complications. So intrapartum guidelines, according to WHO, every woman has a choice to select the mode of delivery, plan of birth and companion of birth. I remember when COVID came and one of my colleagues called and said, how you will deliver a woman who has COVID during this pandemic when it's on peak? I said, what do you mean? She said, oh, I'm not going to take care of her and I'm going to go do cesarean section. And I said, no, this is not right. So if we are afraid to take care of a woman who is labor, which can happen 10 to 12 hours, this is not excuse to shortcut the process and put her more into vulnerability of getting the disease. So cesarean section is only indicated if it's medically indicated. All women should be screened for COVID-19 between 38 and 39 years, because this is the time she is at risk of intervention, which could be delivery, which could be cesarean section, any complication, and she may end up in the hospital. So in Dubai, we are screening all the women between 38 and 39, even they are not in labor, just to know their COVID status, because if there comes an emergency, then there is no problem. But any woman who's admitted to labor ward at any time, the COVID screening is done. So in 24 hours, we know their status. So as I told you, yeah, all the women should be screened for COVID-19. Obviously, staff should be minimized in labor ward. There should be only one nurse, and same nurse should continue the care of of the patient. And same doctor, I know doctor has shifts, but try not to change the shifts, try not to change the caregiver because then it's more exposure. And appropriate PPE should be worn by all the medical staff. Airborne infection isolation room should be reserved for aerosol generating procedures. For example, somebody is intubated or inhalers or a nitrous oxide gas, but we are not using nitrous oxide gas nowadays. Epidural spine is not contraindicated. For high-risk women, the neonatal team should be informed at the time of admission, so they should not rush for a fetal distress or they should not rush for the cord prolapse. And we should give them ample time to wear PPE. We should take care of them. It's WHO advice if woman is infected with COVID-19, it's better to keep the baby away from mother. Breastfeeding is not contraindicated, but it's the close contact of the mother during breastfeeding. I'll come to it later. Right, postpartum guideline, woman, mother who is COVID positive but asymptomatic, rooming in is possible. And direct breastfeeding is advisable with strict infection measure, that means she can wear the mask or wash the hands. Although we are now getting the face screen very easily, it's not a big problem. When mother is too sick to take care of the baby, baby should be managed separately, and somebody should feed the fresh express milk. Milk is not the problem, it's the contact with the mothers. Visitors should be limited in the room. All can go and see the baby and mother at home, but again at home they should be limited. And any person with unknown status, they need to wear masks. At least masks should be worn when we are going to a lady who has recently delivered. If the separation of neonate is not possible, then a curtain between a mother and the baby, keeping the baby 6 feet apart away, using a face mask, and head hygiene is possible. And I was really amazed when the mosques were open and I saw the people, namazis, they had the plastic curtains. So Pakistan is very innovative. And I think the time where we can initiate the contraception is in the postpartum period. We don't need to run after them. If the woman is, not very well educated, injection of long-acting contraception is the best. And obviously I have seen, doing postpartum tubal ligation, but I think it's very barbaric. And please, I think I would go against the postpartum tubal ligations because one thing is done under local and chances of infection, everything. The best thing is to give one type of Provera injection. That's the best thing. Now, everybody knows this WHO organization, the bulletin, the website is there, and it's updated every day. So I think all the people who are taking care of the other human beings or who are in the health profession, they need to keep reading this every day. I don't need to go in detail about it. So I will just go to the main headings. So operational strategies for maintaining essential health services, the documents there, please go through it. I've shown the website and it's updated every 2-3 days. So I go and read it every day or at least once in a week. So daily reviews, every country has a COVID response team. I'm sure Pakistan has a COVID response team, which should include the medical professionals. So they should go through it, and these strategies should depend on the provisional, national, and global figures. All elective and non-essential service should be reviewed on a regular basis, because in the way when the virus was at peak, every week we were getting the bulletin and the guideline that we have still the dental services are closed, still the cancer chemotherapy is closed, still the elective, and this is open. So slowly, gradually, they started opening. So it means we need to have these guidelines on a regular basis, and people should be informed, the public should be informed, the doctor should be informed, and everybody should be informed. There should be a good communication. The main stay of this COVID-19 is communication. Practical action should be also taken at national, sub-regional, and local levels, and everybody should follow the bulletins from WHO. Now, how to establish a safe and effective patient flow at all levels, which is screening, triage, and targeting. These are also there in WHO guidelines. I would ask the government, I'll ask the healthcare system, I'll ask the professionals to go through it and make it on a local basis. As Dr. Talib said, 18th amendment or whatever, that Subai Hukumuto ko power, I think we are doing it. I was very, very happy to see the Chief Minister of Sindh, and he was updating everybody, and he was doing a good job. If the doctors, they want to get more information, they should go to CDC documents, which are released on a regular basis, and they are used for non-US based healthcare settings. And obviously we have SOPs, and we can get more SOPs from them. So I don't need to tell the people because what to do. These all depends on the government, the management, and the public there. Now, again, I'm coming to sexual health. So the best method is one which works. So there's no any method. You have to talk to the patient or the person or woman and see what she wants and what is suitable for her and what will work. For example, a young woman, if you give her a pill and if she has 3 children, she'll forget taking the pill. So I usually advise them to have a IUCD, forget about it. And other thing which is very important, I always tell the woman, you should be in charge of the contraception, not the man. So women should she has to take the responsibility of contraception. So the barrier method, they always fail. And obviously, it's COVID-19, we should use non-invasive methods. Which is probably in Pakistan, if you're going for general population, not the women who are fully aware of different way of contraception, injection Depo-Provera is the best method. Right, so now FIGO, and as Dr. Talib is already there, so the mainstay of contraception family planning is to supply and to give the essential services to the women, which is their fundamental right. And he knows everything about UN Secretary General and FRCH and all those things. And all I advise to make healthy policies, to make logistic arrangement, to supply chain of the contraceptive across the border. I'm quite sure Pakistan has ample supply, and Pakistan is very, very advanced in this specialty, and they are doing a lot. Now, what are the FIGO recommendations for standard of policy of sexual health? So there's urgent need of expanding postpartum family planning method. As I told you, the best way to give, rather than LHVs going to the villages and begging the women and women not listening, then and the long-acting reversible contraception system. Obviously, I don't like really putting an IUCD postpartum. At least it should be 6 weeks apart. But the best way to give Depo-Provera injection. Self-care family planning method should be promoted and supplied to the women and men both effectively. Barrier to access to the contraception method need to be lifted without compromising safety, installing vending machine over the counter, availability of ample supply to the community center. I know we have a lot of community center in Pakistan, so I'm sure they have a lot of supply there. Installing vending machine is a bit delicate issue in Pakistan, so I don't know how they deal with our reproductive and sexual department in Pakistan. Over-the-counter availability is there. Implementation of telemedicine through mobile phones, social media as adjunct to the improved information access to the contraception. It's very important, and we have a bit taboo to advertise contraception, family planning products on the screen, but we should not advertise like India does. Not should be direct. I think we should be just advising that safe gap between the children, will improve the health of the mother, will improve the upbringing of the baby, and makes the family happy. The old-fashioned, advertisement when I was young, we used to see the families, playing in the fields, and they're happy, and they have 2 children, and whole family is good. So we need to change our way of the media, how we want to advertise it. Now, this is the communication strategies during digital platform. So designing apps as SMS services by the government will be helpful. If the government has the database of the women who have delivered at a home, or if you have data that how many children the family has, it's a good way to know if a family has 6 children or 8 children, and they don't know what the spacing of the pregnancy. And everybody has mobile phones, so sending the SMSs will be a good way. And government should plan ahead to have supply chain challenges, so there shouldn't be any shortage of the contraceptive. And the healthcare should be provided adequate PPEs. I know Dr. Talib spoke about that their department need PPEs. Dr. Talib, PPE is not a problem. It's just a paper thing made of paper. The mask, they are very cheap, and gloves. I think the doctors or the people who are there should be given confidence that if they wear the mask, if they're wearing the glove, and if they're wearing like a gown made of paper, or they can make their own gown of cloth just to cover their own clothes, enough. So they should not be scared to deliver the service of sexual health and family planning to the community. And community engagement should be enhanced, because I know there's a lot of resistance from the religious leaders, but if they are also engaged, that we are not saying stop having children, we are saying have a safe gap between children. You can have 10 children. I don't know, I think if she has 10 with a safe gap, she'll become menopausal. And this is the way, have a safe gap. And a lot is done in Pakistan about innovation technologies, and we should introduce we should give the youngster the chances to do innovation. Now, this is the most important topic, and this is my second last slide. Pregnant women need a lot of support during pregnancy anyhow, but this is a very important time. Patient education, mental support is needed. And the first patient education, mental support starts from the doctor, where the patient come and sit. This is the first contact. If this doctor is kind and she takes a bit of time, give some information on a piece of paper, that's the first thing. And then later we can do it by radio, by television, by pamphlets, or by any means. So now we have more difficulties that care should be available to the women, because we have now more complex problems. We have isolation. I don't know how much isolation is Pakistan, but here we have isolation. Financial difficulties, people were in very good jobs and suddenly they lost the jobs. Insecurity, what will happen in the future. And access to the support system. In UK, there is a lot of support system by social securities. There are family help, and all these things that happen because people pay their taxes. And in Pakistan also, I'm seeing on media, there is a lot of support, but it should be properly targeted to the women who are pregnant. I remember when I was very young, a pregnant woman was given special food, a bag of soya beans or some rice or some cooking oil rich in vitamin D. If we do this gesture, this will be also beneficial along with the family planning services. So obviously corona pandemic has increased the risk of perinatal anxiety, endogenous depression, sleep deprivation, malnutrition. Support is crucial. And I was more worried about the woman who's undergoing this and carrying the babies, and those babies who are delivered in corona period, what will happen to them when they will grow up? Because in utero circumstances helps the personality of the person. So we haven't seen now what will the outcome of these children when they will be 10 years old and 12 years old, they'll be adult. So my last slide is, this is my son who recently had a baby in Corona period. So they are in isolation, but they are having good contact with the nature. And this is the way he's developing his baby, and inshallah, he will be a happy baby. Thank you so much.
Thank you so much, Dr. Sheikh, for such to the point and yet very comprehensive presentation regarding female sexual health and what we should and can do during this pandemic. Before I move forward to our next speaker, there are a couple of things I would like to say to my participants. Is that please, we are live on Facebook as well. So if we couldn't admit you, I'm really sorry, but you could see us on Facebook. We have got a Facebook page called The Impact. If you could go, all our previous presentations are there as well. If you could go and like our page, that will be very helpful for us. The other thing that we request during each session and is very, very essential for us to work on our future sessions is if you could please fill in the feedback forms. I'm sure Said Sumro, one of our leads in the project, have already forwarded you in your emails. And if you haven't got them, it has been uploaded on the chat box, so you can get it from there. If you could please fill in there in those forms and send it to the Gmail address of Impact. The Gmail address is there in the chat box as well, but I'll repeat that for you. It's the Impact 2020uk@gmail.com. If you can please fill in the feedback forms, that will be very, very helpful. My next speaker is called Dr. Muzaffar. She is a Dow graduate, and she's been in UK for the last few years and has worked in various cities of England, getting diverse experience all over. She is an established GP currently and has a specialist interest in family planning, and she runs her own clinics in East Riding of Yorkshire for family planning, and has been closely affiliated with Hull and York Medical University and is very active in teaching medical students. So I would like to invite Dr. Samreen Muzaffar, who will be enlightening us and will be discussing and facilitating contraception on the whole. Thank you so much. Over to you, Dr. Muzaffar.
Thank you so much, Sadaf and the whole Impact team. Assalamu alaikum, everyone. Thank you, everyone, for joining. Dr. Sheikh has given a wonderful presentation and shared really important experience and points with us, which we all need to be aware about. So what in my part of presentation is, she already mentioned that family planning and women health is one of the really important, irrespective of if it's COVID or non-COVID. We all need to be aware, and as everyone is doing a great job in Pakistan, it's more to share and refresh our own knowledge and experience. And also, like, it is still, I feel that this is one of the topics which is still people are not very confident to talk about at times in Pakistan, and many female, they are not aware about the choices and the decision they can make. So in my presentation, I will be going through the contraceptive choices and how COVID has affected and the changes which we can bring can help. So just bear with me for a second. I will share my presentation with you all.
Thank you so much, Samreen. I was just going to say.
Just so that I think there is some problem. I'm just trying to share
I believe you need to open the presentation and then
Yeah,
from
it's
Zoom. Yeah.
it's already open. I'm just can you see? Just give me a second.
Yeah, we can see your desktop. I believe you need to open. Yeah, yeah, that.
Can you see? Okay.
Yeah, yeah. I think you need to start from the
Yeah,
beginning. Yeah, yeah,
that's fine. Thank you.
yeah.
Okay.
Sure.
So when we talk about the contraception, and there are a few things which, being professionals ourselves, and in primary care, when I deal with the family planning and contraception, these are the principles which WHO has highlighted too, and which is very important to keep in mind. These 9 principles. That first of all, as Dr. Sheikh mentioned as well, that it is very important that the person, the female who is coming to us to discuss in regards to contraception, she should be fully aware and have the rights to make the decision herself. We also make sure that there is no discrimination in regards to whoever is coming. We discuss with them all the choices which are available. What are the resources available? They should be fully aware where to approach. That is very important. The centers which are nearby, like in Pakistan, how they can get the information, who to approach, what are the options are available in the pharmacy. That is important too. Because many times we did discuss things, but if there is not availability of the right options at the pharmacy, that won't help them. Also being aware that we as professionals are up to date with all the new guidelines and changes which is coming, so that we can keep them also aware what's happening. For the contraception as well, I always believe in that it is a informed decision. It should be that the females are aware that what we are telling them, and it's a mutual decision. It's not just a doctor-centered approach, but it should be the patient decision to make. Keeping over here as well the confidentiality, and reassuring them that all the information which has been shared is between the doctor and them, and also making sure that they have equally participated with the rights, that they can make the right choices. So as we all aware, there are lots of options available, and usually the contraception, which is categorized into the hormonal and the non-hormonal contraceptions, which is also very important to be aware about what are the choices available. So if a female is coming to me and like to discuss that, when we, first of all, I give them the choice and I explain to them what are the options available. Then discussing with them that what they would like to choose and opt for. For this, there are lots of factors to keep in mind. It's not just giving the choices, but also being aware that keeping in mind the age group they are in, how, again, when we are discussing in regards to either this is the pill, again, they're with the age group, that will they be able to take it regularly? Will they be compliant with it, taking it at the right time? Because this is very important with the contraception if we are going for the pill form. Also, making sure that there are no underlying medical problems. So, and over here, we do follow a system on which is called as the UK MAC. in which we make sure that we have gone through keeping in mind with the weight, keeping in mind with the age, any other medical problems, if there is any history of heart problems, blood pressure, if there is any history of, you have to keep in mind that one of the things which is very important to keep in mind is any history of any thrombolism, any clots, if she had before, or if there is a family history, we need to know. So all these things are very important, which I'm sure like you all will be aware that it is very important to keep that all in mind when you're discussing with the female, and they to making them clear that these are the factors that will help to make the right choices. In this slide again, mentioning that when we are discussing, so also making them aware that the options which are very effective to least effective. Barrier methods, yes, they are available, but they are the least, the failure rate is very high with them. So it is very important to make them clear, because many times females are not able to understand that, and they feel that they have been using it and why still they got pregnant. But it's very important to be aware that yes, they are the contraceptive choices, but the failure rate is much higher with them. So so again, like making them aware that which ones are the most effective one. And that's why the term long-acting reversible contraception has been brought in, with the implants and the coils, which have a very great successful rate, which I will be talking about more. As I mentioned, that this is the it's a long 9-sheet page which has been mentioned in the Family Sexual Health website on the UK side, on the WHO side as well, which when we are discussing or we are like planning to prescribe, we have to make sure that we have undertaken and checked that which are the risk factors which we have to keep in mind, and we can't prescribe the contraception. So again, like it usually mentions the category from 1 to 4. So 4, if like it shows that there's a risk factor, for example, for the contraception, if some female have a history of migraine with aura, so that is a 4. That is like complete no, that yes, you should avoid giving the pill and look for other options, the combined pill. So this is available, like you can check on the WHO as well as the UK Faculty of the Sexual and Reproductive Health link as well. I will share the link in the end. Again, keeping that in mind, that mentioning that long-acting contraceptive have a much greater impact in terms of preventing the pregnancy, as if it's taken the right way, especially with the implants and the coils, being aware that especially with the implants and the coils, it's also important to be aware that when it's done, that is also important as well, and have the females have taken the right precaution for the next 7 days for the barrier methods, if it's done in the cycle, which is after the first 5 or the 7 days. So talking about the pill, pill is still, it is a very popular choice. I still see a female coming and asking for the pill, as they feel, many females feel more comfortable that they are able to control it by starting and stopping. Again, there are like different, it's usually, I saw that it's female thinks that the pill can be taken for 3 weeks, and then there is a pill-free week, but now there are lots of combinations available. Many female find it that if they are taking it longer without giving a gap, that helps too. Again, it's also available in the patch form too, which we are using here, and that is applied weekly, then for 3 weeks, and then giving a break. Vaginal ring is also another choice which is available here. And so again, with the pill, we have to make sure that we have discussed with the female. When to start, that's also very important. As I said, in the first 5 days, it is much more like that's what we recommend. But if they can start at any point in the cycle, making sure that they have taken the right precautions with that. Also, making sure that they're aware about the risks and benefits and the side effects too. So afterwards, if they are coming to you, so they are already aware and they're not stopping it too quickly, because it does happen that if they start in the beginning, if they had some bleeding and they feel that, oh, this will continue forever, but we need to make sure that it's the first 3 to 6 months which can take to get settled with the pill. With the combined pill, few things which I'm sure you're already aware that we have to make sure is regarding the age group, is regarding the weight. Again, blood pressure, if it's 160 above 100, it's a no to start with the pill. Again, if there is any history of VT, the thrombolism, or if the female herself is currently having breast cancer and is on treatment, so it's a definite no for that too. Also, to be aware and that what to do if they have missed the pill. So also it is very important to make them aware that what they need to do if the pill has been missed. I won't talk more in detail about that, because I will just mention that, yes, guiding them in the right direction, that's important, so to avoid pregnancy. And if they have missed more than 2 in the first or the end of the cycle, they have to be aware that then they need to get the emergency contraception if they have the unprotected sexual intercourse. Again, there are some myths which we commonly come across that, oh, I will gain weight. No, with the combined pill, there is no evidence to suggest that there is a weight gain with that. Many females, especially, I've heard that they mention that taking pill or being on any of the form of the contraception, they won't be able to, their fertility will be affected. This is not the case. Most of the contraception which is available, once they have stopped, either it's the coil or the implant or the being on the pill or the injection. Injection, yes, there is it can take a bit longer, but they will be back to their fertility. And also, this is again the myth that will affect their cause hormonal problems. No, again, this is to help you and it has helped, like the combined pill has been used even for the acne treatment to help many females. The other option, which is again a popular one, and I would say that especially in the current COVID situation, we have found that this is one of the pill option which we have asked many females to use that, because with the combined pill, one of the things which we have to make sure is checking the weight and the blood pressure every year. With this pill, we don't have to worry about that. It can be used throughout. And again, making sure that we have checked the suitability. It is one of the popular choices because there is no age limit for this pill. Keeping in mind that there are some liver enzyme inducing drugs that can affect, and also making sure with the timing again that it has been started at the right time. And with the progesterone pill, it does comes into combinations. So taking at the right time, because one of the combination desogestrel, you need to make sure that it's taken every day, not more than 12-hour difference. Otherwise, you will be more at risk of getting pregnant. And there is also another one, Cerazat, which we make sure that females are aware that it needs to be taken not more than 3 hours apart every day. So pills, yes, they are the good choices. But again, when we talk to females, we always mention that because with the pill, there is chance of forget to taking the pill, they miss the pill. So the long-acting contraception, we always discuss with the patient and give them this right choice to decide herself. So in the long-acting contraception, we have the choices of the implant. With the coil, again, there are the choices of using the hormonal one and the non-hormonal one. Same goes with the progesterone injection. So they are all long acting and can be used for a long period, which have much more higher, less failure rate, I would say. And they are very reliable as a contraception to be used. So talking about the injection, there are, it comes in different combinations, and the depot injection, which is which has been there for a long time and has been a popular choice too, is effective for 12 weeks plus 5 days. So females, many females, they are happy to use that, and especially many females if they have a problem with the bleeding and they would like their periods. So it has been effective for menorrhagia, and so it does help in the first year to settle down. Either they won't have any bleeding, or some can still continue with the bleeding issues, so which can be managed, but it have to make sure that you've contacted your doctor to discuss about it rather than stopping it. Again, with all the other contraception, it is important to be aware of the timing, to be done in the first 5 menstrual days. That would be better to use. With the age group, but there's a limit for the age group because there have been concerns in regards to the thinning of the bones. So age group above 45 or someone who is less than 18, so we are cautious about it. There is one of the things which females need to be aware that yes, there can be a delay in the fertility once the injection has been stopped. I will just mention that there is one Sienna press, which is a new one which we are using here in UK, and it is given subcutaneously, but females can do it themselves. So the nurses over here, we just make them aware what they need to do, and they are doing it themselves. So it has, during the COVID situation, it has been used here by the females themselves, and we have encouraged them if they like to continue, so they can do it themselves. And then through the telephone and the video consultations, we have discussed this option to be used. Implanon it's a very popular choice here, and I do regularly see females, and they again with this either in the first year 50% they will like to use it if they have no side effects, because bleeding is one of the problems, and many females found some mood changes which can happen, and they can notice in the first year, and many end up like asking for it to be removed. It is licensed for 3 years, but the key thing which I always mention to females, that if in case, like many can be amenorrheic, but some females, if there is an issue for the Implanon with the bleeding issue, so we can give the pill along with that just to regulate the period for 3 months, and it has helped many females, and they have been fine and no problems afterwards. So for the coil, again, there are talking about the non-hormonal, the copper coil. It is also many females that when they prefer that, they do not like to have the hormonal option. We discuss with them this option, making sure that they don't have like problems of heavy bleeding, because the copper coil can make the bleeding heavier. So it is not, we don't recommend if someone already have a history of the menorrhagia or the heavy bleeding. We have got the preparation, like 2 forms that it can be used for 5 years and a license up to 10 years as well. And there's no age requirement to stop for that. It can be continued above 45, 50. And it is also used as a very effective emergency contraception. It has a very high success rate to be used. Mirena, it is the hormonal progesterone option, which is a very effective and a very popular choice again here. As it is also very popular among females who are above 45 too, because you can keep it longer, more than 5 years, in females who are above 45. It is one of the very beneficial choices for females who are have heavy periods. Again, with the heavy periods, need to make sure that there is no other underlying cause and you have done the ultrasound or ruled out other causes, then you can go ahead and do the Mirena coil, because it is it's a very effective one to help control the bleeding. The other good point about using the Mirena coil, that it can be used as the progesterone component for the HRT purpose in females when they are struggling with the menopause side effects. So I do regularly prescribe and use Mirena. As for the HRT, the only difference is that for the HRT, it is licensed to be used for 4 years. So we have to replace it after 4 years and give along with that the estrogen pill form. Mirena can't be used as an emergency contraception, so we have to keep that in mind. There are other forms of the intrauterine contraceptions, the hormonal one, which is available. And some females, like instead of the 5 years, or the young female, the JADAs, I've done in quite a few females, which like to keep it for 3 years, and it's small and less painful to be used. So there are other options which is available, but they can't be used for the keeping in mind for the component of the HRT. Sterilization, yes, it is one of the effective options which is available. Again, it is, we don't use this option these days much. The reason, as the LARC options, the long-acting reversible contraceptive options, are available, and it is very important to discuss fully the risk, reversibility in the long term. What if they are thinking at this point to get the sterilization done, but afterwards they decided for any change in family circumstances with, or if the child has some medical issues, and then afterwards they regret that why did they did that. So we encourage more and more for the LARC options to discuss, in which they are able to control that, and they will be able to, if any they decide afterwards to they need to stop with the contraception. Still, if they like, again, we give them the choices for the female, and for also like discussing with both the partners that for the male there is an option available as well, which has a higher success rate and less complications. So this is one of the very important aspect after delivery contraception, which is many females find that, oh, they don't like to talk about it, but also they don't like to get pregnant after giving a baby very soon. So it is very important to make them aware, discuss with them, and when the pregnant females, they are coming, even at that point, mentioning, discussing with them what are their thoughts they will be doing after delivery, so they are fully aware and how that can affect. That's very important, because many females, when they are breastfeeding, they feel that they cannot get pregnant. Yes, if they are, it has to be very clear that if they are fully breastfeeding, they don't have any periods, that is yes different, so up to 6 months, but if they're not breastfeeding and they're partial breastfeeding, or they have added with the top feed, they're not covered with the contraception. So maternity services also over here, they discuss and the options available, because there are options which can be done at the time of delivery within 48 hours, or we do make sure that from day 21 afterwards, they are on the right contraception, because there are all choices which are available, which they can utilize it. So coming to the emergency contraception, this is, again, many females, they do, in Pakistan, yes, they do have, like, they have access for all the pills, which is lots of, like, females I know, they can access directly through the pharmacy. Over here, yes, we make sure that they have got in touch with us and discussed with us for the right choices which can be administered. Timing is very important, that many females, they don't realize that why, what's the reason. So if they have, making sure when they had the unprotected sexual intercourse, because timing is very important when we are giving them the choices. If it's usually making sure that it's they are ineffective after ovulation, so it's within the 5 days, as early as possible, they will get in touch with us, then we can help them more effectively. Also, many females, commonly which we see, the reason why the emergency contraception needs to be given is if the female have been on pill, they missed 2 or more pills. Again, you have to make sure where in the pack they were, and when the timing also important as well. Again, many female, like it does happens that coil procedures have been done, it has been expelled out in the initial phase, then you have to make sure that they are aware that they need to have the emergency contraception cover. Again, after delivery, the females, as I mentioned, they need to be aware that if they had and they were not on breastfeeding and it's more than 21 days, and if there is an unprotected sexual intercourse, they need to have the emergency cord. So there are lots of reasons, which I'm sure you're aware, which we have to make sure, and they are aware about the timing and approaching and getting the right medication. So the choices is we have the oral and the copper coil. Copper coil is one of the very effective emergency contraception, which again, it's very important because the accessibility, how quickly you can get to see the clinician. And then for the coil and the implant, I would mention that it is very important that you are properly trained. In UK, I have myself been through the full training, and every 5 years we need to keep ourselves, again, renew our training for this. So this is something which cannot be taken lightly. It requires proper training, which the professional have gone through, and only they can do that, because doing these procedures right way is very important. Otherwise, it can end up leading to complications. So, so this is very important, and pill is much easier for the emergency contraception to be available. So again, the choices which we use here is the levonorgestrel or the Ellaone. So again, being aware about the timing, that one is effective for up to 72 hours, the other is up to 120 hours. It's how they act with before the ovulation, they can help. With the Ellaone, you just have to be slightly careful that the enzyme-inducing drugs, they can affect the Ellaone, how it's been, so you just have to be careful that the patient is, that the female is not on any other medications that can affect it. Again, you have given the emergency contraception. Not just giving the emergency contraception is important, but making sure if they haven't been on any contraception, to avoid this happening again. At that point, we do make sure and discuss that what are the plans to go for the regular contraception. So we do make sure that they go on the regular contraception, as this is very important to discuss. So this is again the chart just to mentioning about that, what to do when they are presenting, making sure, and we go through and discuss with them the choices according to the time when they presented to us and when was the last episode of the unprotected sexual intercourse. So in regards to the COVID updates, for the contraception, there is a big change. We used to do the face-to-face consultation, but now I know in Pakistan, there are like very good services I have come across, and people have mentioned to me that how brilliant they are doing in regards to the telephone and the video consultations there too, to provide counsel the females regarding the options. The progesterone pill has been a very safe option to use as a bridging to if we can't give the combined oral contraceptive pill to the female, or if they have high blood pressure or their BMI has been high before, or we have given repeat prescriptions to female if their blood pressure and weight has been checked in the last 12 months. So it can be extended for another 6 to 12 months to continue taking it, which we have been doing here. Again, as I mentioned before, the injection, the Cyanopress, which many females are self-administering here, and they are happy to continue with that, but we are making sure that they didn't have any problems or complications using that. In regards to the Implanon females who have been on the Implanon as it's licensed for 3 years, according to, we have been given that they can extend to use that for up to 4 years. We can use it. But what like I've been doing is making them aware, yes, it can be, but many females still, if they have to be 100% sure not to get pregnant, so we have prescribed progesterone pill on top of that, which is absolutely fine to do that till the services are back to start using, which over here we have start like doing the procedures again. So the females I've spoken a few months before, I've started doing their procedures who are due to have it done. Again, same with the copper. The change was that the one which is licensed for 10 years, we can still keep it up to 12 years. So they're not worrying or panicking about it, but can give on top if it's like, obviously they feel that they will be more happy to do that. Same goes with the Marina Coil, can be used up to 6 years rather than the 5 years. But also just making sure that you have made the right plan and made them aware that as soon as the services are back and we're doing that, they are they need to be done rather than just waiting for 6 years. And as I already mentioned that yes, progesterone only pill on top of the LARC, we have been prescribing here as well, and it can be done. One of the changes, because over here none of these medications are available over the counter, but all the situation has made the likely legislation which is going to come is the progesterone only pill to be available pharmacy drug, because it is one of the safest option to be used, and in females, like especially when the medications are available over the counter in pharmacy, they can use it irrespective of the age too, and also in post delivery. So the key thing is to make sure that we are up to date, and the females, to make them aware that they what are the options available. The websites to signpost them. We do have leaflets over here, which does help many females to use this. Social media, communication is the key, and the more we will talk about it and make the female comfortable and confident, the easier it will become for them. So these are the references I have mentioned, that the WHO, as well as there's a lot of information available. We can signpost, we can read ourselves. I keep myself up to date with that too, and also on the Faculty of Sexual and Reproductive Health of the Royal College of Obstetrics and Gynaecology. Thank you so much. If there are any, I will leave it to you, Sadaf.
Thank you so much, Dr. Muzaffar. This was really comprehensive, and I would say definitely very informative. Although I've got very minimal experience in obstetrics, gynecology, and contraception, I would like to say, being a female doctor, these are the questions that we do come across very, very frequently. I think you've already answered so many of my questions. Before we move on to the questions, I would like to say to my audience and the participants that we will have some more questions that I'll pick up from the chat box. I'll give this time for you to get ready with your questions. But before you ask the question, if you can please introduce yourselves and let us know which organization you belong to. It will be helpful, as many would know where are you from, and we will take it from there. My first question, I would direct this to Dr. Sheikh, is based on international experience, I mean, even in developing countries like UK, we've seen that the domestic violence has gone up significantly. I mean, I think these are not recent figures, but I think it was early July, late June, that the domestic violence reporting in UK has gone up to 53-54%, and the mark has increased. The MIRAC referrals has gone up by 50%, and this is happening here. And I'm presuming, and I think we are all anticipating that this might happen back home in Pakistan as well. Is there any particular suggestion you would like to give to the doctors? How do you think we can affect this, or how do you think we should approach these women in particular? Over to you, Dr. Sheikh. Any insight into this, please?
Yeah, I've seen, I don't know, it's the reporting of the media or it's the real issue, but obviously when there was lockdown and people were locked in their houses, and the husbands who are used to go outside to do work and working from home and seeing these faces every day, obviously these frictions are happening, and on top of it, the social isolation and insecurity and the job and everything, it has made the people stressed up. And I think very serious cases has happened, but how to approach it, the approach is different in different countries.
I agree.
So obviously, I think it's a good thing that in Pakistan, it was not a strict lockdown. So people were still able to, the man was still able to open the door, go outside, although they were blamed that why they are sitting on the dhabas and having tea together, but it's a good psychological effect. In UAE, again, it was not very strict lockdown, but we felt the impact of, working from home and isolation. I think the best thing is the media, and there should be some helplines, and especially it's very important for the women. I haven't seen more women beating the men, but I've heard men beating the women because they are more stressed, because they have the responsibility to bring money at home. So that's the reason I think UK was good. They were letting them out to go to the garden. So the main thing is the lifestyle. We need to inform the family that it's a virus. But now it's most of it over. But I think UK is again very much scared of second wave because winter is coming. So the way to keep the peace and the harmony in the house, first thing is the families should be, the media, the dramas, or whatever is happening. The morning programs are very good in Pakistan. I really like it. They touch the, common problem. That how to deal with isolation and staying at home, having a structured life, going out, some for a walk. And there should be helpline for a woman if she's thinking the man is very irritable and stressed. There should be helpline to call somebody. So basically, it's not a psychiatric help. It's basically third person stepping in and asking what are the problems and provide them help. And this is a temporary problem. And with the spiritual help and with some help from a neighbor, from a social worker, this problem will be sorted out. And there is a very good, somebody said, it's not only viral pandemic, it's the spiritual pandemic. And I've seen most of the people have gone to the meditations and more, believing in Allah. And where I live here in Dubai, the communities, they have started every day doing exercise together, having meditation together. They were live things, and that was happening.
Thank you so much for your answer. I think you're very right, and I would like to add probably that anticipation of the problem can solve many problems in advance. So us as doctors probably need to anticipate that this will happen. So just to be aware and be there to support your patients, because we are the ones who might come in contact with these patients first. Recognizing it would be very helpful for our patients. One of the questions that is raised by Dr. Irfana Tehseen is that my query is if any client who is coming with complaint of amenorrhea for more than a year after insertion of Implanon and even has had hormone regulation pills, what's next to do? Do we just remove, or is there any alternative solution for this? I direct this to Dr. Muzaffar, and if you want to add anything, Dr. Sheikh. Over to you, Dr. Muzaffar.
Thank you. So if with the Implanon in the first year,
yes, she specifically mentioned Implanon. Yes.
Implanon, yeah. So with the Implanon, yes, there are three bleeding patterns that can happen. Either the females, they won't have any periods, like amenorrhea, which you have mentioned. If that's the case, that if they have amenorrhea, it doesn't mean that that means it is the Implanon is effective. You don't need to do anything for that. Just keep the Implanon for 3 years, because that's part of the Implanon. That's why she is amenorrheic with the Implanon. So you don't need to do anything at that point. Just stay with it and reassure the female that what happens with the Implanon. And also many females get scared that, oh, if they don't have period, that will affect their body. No, that's not the case. They will be back to their fertility periods once it's been taken out.
I would like to request, thank you so much, Dr. Muzaffar. I would like to request, if you're not asking the questions, can you please mute your mics? Thank you so much. Another question, but this person has not given their name. Lots of women in Pakistan suffer with PID. Is it safe to use IUD in these women? Doctor, yeah.
Should I answer?
Yes, please. Thank you, Dr. Muzaffar.
So yes, if PID, yes, that's one of the risk factors. So if the female is having PID, if it's been treated and she doesn't have any symptoms, so you can go ahead with the coil, making sure what we do over here is we do the swabs before doing the coil to make sure that there is no risk of infection if this requires treatment. But if she has got the PID, she's not been treated, yes, coil should not be done, and this needs to be first treated and checked and make sure that she has cleared with the infection before doing that, because doing the coil, one of the risk factors which we discuss is the risk of infection.
Okay, thank you so much again. Another question, Dr. Sheikh, I would direct this to you. Vertical transmission, I'm sure you've heard a lot about it, that what are the chances of vertical transmission from a COVID positive mom to baby? What do we do in this situation, and how do we manage these babies in postnates? Thank you.
So far, there is no evidence of vertical transmission because they have checked the amniotic fluids and they haven't found the virus in the amniotic fluid. As I told you, they have found immediate detection of immunoglobulin M in the baby's cord blood, but that they are saying is the close contact because as soon as the baby is delivered. So usually what we are doing here, if mother is COVID positive, we take special precaution for the baby when baby is delivered. So early cord clamping, separation of the baby, and taking baby away from the mother, and obviously not rooming in, keeping the baby away at least for 14 days. These are the things we can do. But so far there is no clear evidence that in utero baby get the virus, or rather baby gets the antibodies.
Yeah. I was, sorry, you were saying?
No, it's okay. You can carry on, your pediatrician.
Yes, I was going to say, I would like to add on that although there is a possibility of vertical transmission, and there have been few isolated cases, I agree, but none of those cases have been positive before 36 hours of the child being born. So we don't really know that it was via vertical transmission or whether the baby has acquired the disease later on. However, I agree what you've said, that if anything, they get the immunoglobulins from the mom. And I would like to use this platform, and I'm sure you've said it in your presentation already, that please, 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 breastfeeding is not a contraindication in such cases. These moms can breastfeed their babies. If anything, they would get some more immunoglobulins via breast milk. We know that to date, there hasn't been any reports where we've detected the virus in amniotic fluid or breast milk either, and they've been actively testing it. So it's just not speculation. The other thing that you said in your presentation was, I don't know what's happening in Pakistan, is to keep the baby away from mom about 6 feet if they are COVID positive. This is not something that we are practicing in UK here. Is it your national guidelines, or I know that WHO has recommended that you said, but is it something that you would like to say anything about, or?
You're asking me?
Yes, Dr. Nissa.
See, I'm not in Pakistan at the moment, so yeah. I think I saw Professor Rubina there. You can ask her this question. But in UAE, so far, we had 2 ladies who were COVID disease at the time of birth. So both of them had cesarean sections.
Okay.
So obviously, babies were taken to NICU for observation, and they were kept away until mother became well. And some of them were preterm deliveries. So they are not like 38 weeks. These are emergency cesarean sections. So they were kept away until mother was well.
Okay. I think you're right there. What we are doing here, and what is the BAPM recommendation, which is kind of a gold standard for here in UK, is if obviously the baby is symptomatic, they're nursed in neonatal unit, and every precaution is taken just like any other patient through the entire hospital. But if baby's asymptomatic and mom is symptomatic, then obviously in those cases, the baby has been taken in neonatal nurses, because if mom can't cater the baby being due to her illness. But however, even in COVID positive moms, if both mom and baby are well, we are nursing them together. Obviously, moms are advised to wear masks, and if they're coughing, to wear the fluid resistant masks, the 3mm and the N95 ones. Okay, we will take the next question. This person hasn't given their name either, and they were just asking that how many times can we use emergency contraception in one cycle? Dr. Muzaffar, if you could please answer that for us.
Again, there is no limit that you will say that yes, you can just use in one cycle. So there is no limit for using the emergency contraception, but what we do is that they have to be careful that if they are recurrently coming with the same problem and using the emergency contraception again, LA1, yes, you can use it if you have used the LNA1 near the time. It's the key thing which I would say, please make sure that if it's happening that you have to recurrently use it, be on the right on the contraception to avoid this, because if you're using it again and again, that can lead to complications.
Okay, thank you so much for your answer. There is just one more question again from contraception perspective. People with strong family history of breast cancer, are they okay to take the contraception pills?
So yes, because because many people think if there is a family history of breast cancer, they cannot take the combined pill, especially with the combined pill. The absolute no is when you yourself have the current history of breast cancer or had before. There have been different studies. WHO has mentioned too that they, on one, when they did the study, checking that is there any relation with the family history, they haven't found. And it has been suggested that they are okay to take the pill. Also making sure that it's not genetic link like BRCA or anything.
Okay, thank you so much again for your answer. I think before we move forward to the before inviting our participants for the question, I would like to welcome Secretary Population Welfare Department, Zahid Abbasi, that he is here. Would you like to say a few words, Zahid Abbasi Saab?
Thank you very much, Dr. Sadaf, for moderating this webinar. I really appreciate the Impact UK, Abdul Ghaffar Ansari, to work with the Population Welfare Department in collaboration with the government of Sindh. I myself was the Secretary Health when this COVID started in the month of February. I had both portfolios of the Population Welfare Department and the Health, and the Minister under the guidelines of the Minister, Madam Azra Pechuo. So I was in the department, and definitely we worked from the very scratch, dealing with this pandemic when this started. So I was there till June, from February to June in the health department, and worked day and night to deal with this very grave situation. During this time, I had the portfolio of this family planning. So definitely at that time, we have a lot of challenges to deal with the issues of the family planning, because already it's very difficult to access to the far-flung areas and other things. So during this COVID situation, our main focus was basically on creating infrastructures and others. So the focus was less, and there was a reason that this family planning aspect was also affected during this COVID, and the coverage was a little bit less during this time. But thanks to different our partners, that now we are collaborating and we are working together to deal with this situation. Pakistan is not far ahead in this, the internet access even to our clients. But as far as the providers, health providers, and the family planning providers are concerned, they are definitely on it. So today I'm very glad to see that all of our doctors of the reproductive health centers are there to attend this webinar, and I really hope that because I have joined late in the end, so hopefully Dr. Talib Lashari, our technical advisor, has initiated this very good initiative. So I hope from this webinar, our field staff and the doctors have benefited well. Yeah, thank you.
Thank you so much for your input. And I would like to say, I know that we've surpassed our limits for accepting this Zoom meeting, but you can always tell your friends who have not been able to join us today on the Zoom that all the videos are there on the Impact page, so you can always revisit, and if there's anything that you want to go over again, it's all there, so you can just log on to Impact page and get all the videos. I would like to invite the audience. I am very aware of the time and we are running short of time, so please, I would say to my audience as well that if you could please ask to the point questions after introducing yourself and your organization, that will be really helpful. I would like to invite you now to come up if you've got any questions for our speakers, please.
Sorry. We are waiting for the questions.
Yes. Is there anyone who want to ask any questions in particular? Okay. I'll say, sorry, did I hear anyone?
Yeah, I think there are some questions. Somebody has written, what type of complications can be during tubal ligation in COVID-19 positive client?
Okay, I can't see these
Yeah,
questions.
it's on Facebook.
Oh, okay.
So can I answer?
Please go ahead, Dr. Sheikh.
So the thing is that tubal ligation, I know that if it's done during cesarean section, somebody has 3-4 cesarean section, it's okay because you have already done the surgery. You're not adding up any risk. But if you are doing postpartum tubal ligation, I would suggest please don't do it because we should avoid any extra infection and intervention when we have so many other methods, as Dr. Muzaffar said, long-acting reversible contraceptive. You can give Depo-Provera injection. The basic thing should be, we should be using spacing, not completely block the tubes. And so wait, let the patient or woman get better, she becomes stronger, and you can do an elective method in a safe environment.
Okay, thank you, Dr. Sheikh. If you've got any questions, I can see some hands raising. Can you please unmute yourself and then ask the questions? I'll just put it us on.
Hello, may I speak?
Yes, please go ahead.
My name is Dr. Kamal Fayaz and I'm from Population and Welfare Department. As you have already mentioned regarding OCPs and the side effects, but some women who are taking for a very long period, I have seen for more than 10, 12 years. And you know, we have strict guidelines that after 40, you don't have to use OCPs especially. But they are very reluctant to use any other method. So how, beside repeated counseling, how is there any way to tackle them, to guide them that you should not choose for it such a longer time, like 10 or 20 years?
So if you're as you mentioned, yes, over here, what happens? Female above 35, we don't encourage using the combined oral contraceptive pill. What we do is that we counsel them, and we did explain to them that above 35, keeping, if you discuss the risk with them fully, that with the long use above 35, the risk of having the heart problems, of having the clots. So you have to make sure there are females who does, if they don't have any risk factors, they can continue up to 50, but above 50, that's an absolute no. But as far as they are fully aware what the risk or long-term risk, and if you clearly mention to them that yes, above 35, we don't encourage, and switching them to progesterone only pill, that's again, she will, if they like to just stay with the pill, progesterone only pill is a very good option to continue, and they can continue up to 50, up to 55. And if they don't want to go on the ideal thing, if someone is on the pill for such a long time period, I always encourage them to go on the long-acting reversible contraception, explaining them it will be beneficial, and they can keep it much longer without worrying about the pill.
Please raise your hands or unmute your mics directly. If you want, I can see Nariman Baloch, who's raised your hand. Would you like to ask your question?
My question is regarding surgery.
Please go ahead.
The method in vogue was surgery, contraceptive surgery before COVID started. And we have highest numbers of surgical contraceptive surgeries in our, we used to do. Now, as we have stopped and there are guidelines that we do not do surgeries, but we have some clients who prefer surgery, are we allowed after doing their test to continue with surgical methods, postpartum mini laparotomy?
Can I talk
Am I
about it?
clear?
Yeah.
Yes.
Yeah. Let me speak to moderator if I can answer.
Please go ahead, Dr. Sheikh. Thank you.
I have seen that we are doing forcible tubal ligation postpartum, just second day, because uterus is still up to them, like it's easy to give an incision and take out the tubes and do, and so many complications that happen. Somebody has grabbed the intestine, somebody has perforated the intestine, somebody has introduced the infection. So it's an added risk in this period where we don't want the patient to stay in hospital for longer time. It's good you are not doing surgical procedure like elective postpartum contraception. As Dr. Muzaffar has told you, there are so many non-invasive, non-surgical methods. Why don't you follow it? And so please, if you have reduced the tubal ligation postpartum, it's a good thing. I would not recommend you to be, be a little bit worried why we are not, because you are happy that you have done your job. But if something happens to the patient in this COVID time, it's an added risk to the patient. And I think, yeah, that's my answer.
Thank you so much, Dr. Sheikh, for answering that. We've got another question in the chat box. Dr. Tehmeena Naseem ne pucha hai. A COVID positive client already taking COCP should they continue taking the pills in this period, or should they discontinue pills until they are fully recovered? Any insight, Dr. Sheikh, Dr. Muzaffar?
Muzaffar, you want to answer? Should I answer?
It's fine. You can answer. That's fine. If there's something else, I will add.
Yeah. I mean, if woman is COVID positive, so COVID positive is not only COVID positive, depends whether she has mild disease, moderate disease, severe disease. If a woman is having just flu-like symptoms and she's well, she's not admitted to hospital, she's not on respiratory support, she should continue. It's not a contraindication. But if a woman is so ill and she's in hospital and she hardly cannot look after herself, obviously you have to stop all the medication. But obviously there'll be withdrawal bleeding, all those things, and Dr. Muzaffar can put more light.
Yeah, as Dr. Sheikh mentioned, that COVID itself is not the contraindication to stop the pill. It depends on if she's at home, she has got some flu-like symptoms, as it's a virus. Yes, when she's on pill, which I'm sure being made sure that she doesn't have any risk factors in regards to blood pressure, heart problems, or any clot risk, she should be okay to continue. And unless she's something that's different, but then it should be fine to continue.
Thank you so much for your answer. किसी और को सवाल पूछना है तो प्लीज आप लोग अपना माइक अनम्यूट करके क्वेश्चन पूछ सकते हैं. I'm just looking. अगर कोई हाथ raised है तो I can't see anyone.
There's a very interesting question.
Okay, I'll let you.
So somebody, Shabir Sadio has written, does it mean the safest method? Why not it is promoted as a part of contraception? Right? So my answer is also very interesting because it's a manhood, and in Islam, if men can marry 4 wives, and if a wife died, then he marry another. So from our cultural point of view, it's not accepted by men. If a man accepts in Pakistan to have vasectomy, he's a very great man. But in West, because they know they have one child, even they don't have any children, they go for this method because they don't want to have, somebody taking their name or carrying on their, being a child. So it's voluntarily by the man. So, but this method should be man should be aware of it. Then it's his own choice. You can't do it like in India. You do, forcible vasectomy for the man. So all sort of contraceptions are voluntarily. You have to give the information, let them choose.
Okay. Thank you. किसी को कोई सवाल पूछना है, प्लीज अपना माइक अनम्यूट करके आप क्वेश्चन पूछ सकते हैं. मैं फेसबुक पे देख रही हूँ if there is any other interesting questions.
Sadaf, I can see hand raised. Shayan, Tunio.
Yeah, I tried to unmute her, but yes. Shayan, Tunio, अगर आपको अपना सवाल पूछना है तो please go ahead. Shayan, can you listen? Can you hear us? Okay, एक और सवाल है Facebook पे. If any client has amenorrhea, a patient is negative and is advised for family planning injection. And if the injection is done and 2 months later, client comes and tells she has pregnancy. What do we do? Does the injection depose side effects, has got side effects on her pregnancy? Either of the speaker, I'll let you pick.
If she had amenorrhea first, you have to, giving any injection or anything, you have to make sure, yes, she did the pregnancy test, that's fine. But again, also making sure that you have ruled out any other secondary cause of amenorrhea too. Doing all the tests and even you have to do the scan. If all has been done and then you go ahead with the injection, and she found out after 2 months that she had, so again the same problem is that if she didn't had the injection in the first 5 days menstrual cycle period, and if she had any other time and not had any other extra precautions being advised, so that is more likely because the reason why it has happened with the unprotected sexual intercourse. So injection, yes, because it stays in the system, it will have effect, but again, now it's been done, you can't reverse it. So so you go ahead and then contact your gynae team for the further test and scans. So that's what you have to do.
Thank you so much, Dr. Muzaffar. This is just one another question. अगर किसी को कोई सवाल पूछना है तो please आप लोग, we've got another few minutes left.
जी मुझे सवाल पूछना है डॉक्टर सवा BHU शेख बिरक्यू.
Thank you, Dr. Sabah. Please go ahead.
जी मेरे पास दो क्लाइंट आई थी और उन्होंने जो है ये जेडल रखवाया था. उसके 3 या 4 मंथ के बाद जो है वो प्रेगनेंसी के साथ हमारे पास आई. तो वो जेडल जो है अब उनका पॉजिटिव यूरिन टेस्ट करवाया गया था, यूरिन प्रेगनेंसी टेस्ट पहले करवाया गया था या नहीं वो मुझे नहीं पता. लेकिन वो कहती है एक पेशेंट ने कहा कि नेगेटिव था उसके बाद रखवाया है, लेकिन अब वो प्रेग्नेंट है तो मुझे जेडल जो है वो रिमूव करना होगा उसी वक्त ही या मुझे क्या करना चाहिए? कोई मसला तो नहीं होगा उसकी प्रेगनेंसी पे या क्या?
Just to mention that when she mentioned when the females are coming and saying जो है वो the pregnancy test, we make sure that you have to make sure you've done the pregnancy test, it's negative. Also making sure that they didn't had any unprotected sexual intercourse in the last 3 to 4 weeks, because the pregnancy test is not negative immediately, it's not positive immediately. So it's usually after 3 weeks of the unprotected sexual intercourse, we say that yes, it's the reliable if it's positive and negative. So you have to make sure when you're doing this procedure that you have checked fully and they have clearly mentioned that if they were not on contraception, that they didn't have any unprotected sexual intercourse. So that's first thing that females need to be aware. If you're doing the coil or if you're doing the implant, it's the same rule for both of them. You don't do the procedure unless if that's the case till 3 weeks the test is negative. If now, as you mentioned, you have done the procedure and now she's saying so aapko you have to remove the you have to remove the JDS immediately, like arrange for that, and then yes, to the same way, like again doing the blood test, all of the rest, just to make sure okay, how far she is, and then so yes, removing the JDS.
Thank you so much, Dr. Muzaffar. किसी और को अगर कोई सवाल पूछना है, I can't, मुझे कोई raised hands इस वक्त नजर नहीं आ रहे हैं.
Samreen, I have to go now.
Okay, I think on that note, I can't see any further questions as well. Thank you so much, Dr. Sheikh and Dr. Muzaffar. It has been a pleasure having you on board today. You've answered many questions even before people asked them, and it has been a very, very fruitful session. Before we move on, I would like to thank again the Impact team who has given us this platform that we can actually reach so many people and answer their questions. I would also like to thank the government of Sindh because it has been possible thanks to their collaboration. The vice chancellors of many universities that have joined us today, Yarane Watan, and the few people who came and spoke, Dr. Talib Lashari, Dr. Khalid Masood, and Zahid Basi Sahab. Thank you once again. Before we finish this meeting, I would like to say thank you to all the participants for actively participating and putting your questions forward for us. There are a few who must have woken up at 6 and 7 in the morning in countries like UK. Thank you again. If you've got any further questions, you can leave it in the comments on Facebook and we'll try and answer them if we can. And I think on that note, we would like to end. Yes, just one more thing. Please do not forget to fill in the feedback forms and email it to us. Thank you. Thank you so much.
Thank you. Bye-bye.
Thank you.
Thanks, Dr. Muzaffar. Thanks, Dr. Sheikh.
Allah Hafiz.
Allah Hafiz.
Hello, Assalamu alaikum, ma'am.